Hi, Graham. Oh, sorry.
Hi, Kwazi. Can we just check if your slides load up? Okay.
Hi, yeah. I was thinking that too. Okay, let me check.
I've enabled sharing, so we can just check.
Okay.
Yeah, that's fine. That's very clear. Yeah.
Is it fine?
Yeah, great.
Okay. Should I unshare it or leave it?
I think unshare it, and then we can load up again
Okay.
when we're done talking.
Okay.
Great. Thanks very much. Yeah.
It was a mess. Oh, I thought from you.
Okay, good afternoon, everyone. We're going to start our weekly Department of Medicine meeting. This afternoon, the format is an invited speaker. If I can just ask people who are not muted to mute. It's a pleasure to introduce Kwazi Ndlovu. Kwazi is the head of the Division of Nephrology and Hypertension at UCT in Groote. Kwazi is a graduate of UCT, obtained his MB-CHB in the early 2000s, and then specialized in internal medicine and nephrology at UKZN. Also conducted his PhD there, focused on HIV and kidney disease, and was then head of clinical unit at the University of Free State before taking up the position of head of the division at UCT in the midst of COVID, I think in around May, if that's correct.
Yeah.
And I've asked Kwazi, when we had discussions around the topic for today, if he could sort of focus on the issues around patients who have end-stage chronic renal failure on dialysis. You know, it's an issue that obviously is the focus of colleagues in the renal unit, but also on the G floor. I think in general medicine, we get to meet several of the patients on chronic dialysis each year in each firm, patients admitted with complications related to renal disease or other medical conditions. So it's really important for us to remain up to date with these issues. So we're really looking forward to the talk today, Kwazi, and over to you.
Hi, thank you, Graham. I have to admit my camera is quite bad and poor, so and you have to forgive the quality of my image there. But thank you for the invite.
I'm just going to mute some people there, Kwazi. Okay. Do you want to load up?
Sure. Can you see it now?
Yeah, it's fine now.
Okay. Yeah, as you said, my brief is discussing the complications that you get on patients who are on chronic dialysis. I'm going to try to keep it at a basic level, at the level of a physician, and try and sensitize people to the kind of problems that patients who are chronically on dialysis they're likely to face on the complications. So the other of my talk, so I'm just going to briefly touch on a summary of the complications that you get in basic CKD and in the mortality trends that you get associated with chronic dialysis. The various complications that you get with cardiovascular, nutrition, anemia, hypertension, psychosocial issues. As a review, okay, this is something that you all the registrars should know. Okay, the basic complications of CKD range from cardiovascular manifesting as atherosclerosis, hypertension, cardiomyopathy. You have endocrine disorders manifesting as menstrual disorders, sexual dysfunction, and pregnancy disorders, and the likes. GIT disorders, nausea and vomiting are quite common. The hematological, everyone knows about anemia due to erythropoietin issues and the disorders leading to bleeding tendencies and coagulopathy. And of course, the infection risk that is associated with the uremic environment. Neurological complications, they range from loss of consciousness, sleep disturbances, seizures, strokes, and on. Fractures are quite common. Skin tend to be dry. Pruritus is quite a common complaint. And in a variety of complex settings, fatigue, impotence. So this is just a summary of that are attributed to CKD, uremia, and all other issues that are due to a failing kidney. And so these complications, they they start in the later stages, depending on what complication it is. Some start in earlier stages, but as CKD progresses, the prevalence the manifestations of these complications becomes much more overt and important. And so what does dialysis do? So we know that dialysis is an artificial kidney. It restores the excretory function of the kidney. So it's good at normalizing plasma electrolytes, removing fluid and toxins, and it does well to minimize the uremic symptoms and signs. So it tries to mimic the glomerular filtration function. So it can approximate the size barrier, but it fails to do other functions of the native kidney, such as selective reabsorption and the metabolic function. So we rely on the dialyzer as our sort of artificial glomeruli. However, when you use a dialyzer, you have issues of biocompatibility, and dialyzer interacts with blood components and activate white blood cells, platelets, components. So you get this low-grade subclinical inflammation, which has various adverse outcomes. And you from infections, accelerated atherosclerosis, frequent admissions, and as well as mortality. Okay. And what about mortality? So, okay, in dialysis, mortality, this is USRRD data in 2018. This is dialysis mortality. This mortality has somewhat decreased, decreasing trend over the years, but we haven't really matched the kind of good, better outcomes that you can get with transplantation. So, but dialysis is still associated with a number of complications and a huge mortality risk. So what causes death in these patients, okay, or on dialysis? So cardiovascular is your leading cause, which accounts for about 40% of identifiable deaths. You also have infections, which is the second leading cause, accounting for about 25% of death, and the third of all hospital admissions will be due to infections. So there are various other causes of death. Okay, so what about the cardiovascular complications, which are the major issues, the major reason why patients would be admitted or die? Okay, so you have sudden cardiac death. You can see that the incidence of sudden cardiac death in the general population is relatively benign, but as you have, as the GFR drops, the incidence starts to grow and grow. And when you put the patient on dialysis, the incidence suddenly skyrockets. So you get exponential growth of sudden cardiac death. So there's something about dialysis that influences this. There are a number of factors that have been identified. We have dialysis factors such as low potassium, rapid solute shifts, rapid water filtration, intradialytic hypotension, the long interdialytic period. So studies have shown that there's a sort of a constellation of deaths in either Monday or Tuesday after the long weekend. So that long interdialytic period is notorious for sudden cardiac death. On Monday when we start dialysis. Okay. Patient factors, age, of course, is an obvious factor. Inflammation, poor nutrition, and comorbidities, diabetes, HIV. So all these are important factors that influence patients suddenly dying from a cardiac cause. The state of the heart itself is important. Cardiac dysfunction contributes. If you already have a failing heart, your chances of sudden cardiac death rises, left ventricular hypertrophy, vascular stiffness, vascular calcifications. All these are important contributors to patients suddenly dying on dialysis. So you have your Framingham factors, which are classically known as your traditional cardiovascular factors. So how do they fare in patients on dialysis? So we know that your atherosclerotic cardiovascular factors such as diabetes are also important in patients on dialysis, hypertension, low physical activity, and left ventricular hypertrophy, which is the predominant factor causing cardiovascular compromise in patients on dialysis. Cardiac MRI is the gold standard in terms of assessing this marker and quantifying the mass of the left ventricle. And it's nice because it can also demonstrate the myocardial fibrosis. Contributors of LVH that are attributed to dialysis itself, things such as the fact that you have repeated myocardial injury that you get each time you put a patient on dialysis. You get perfusion to the heart, and this is thought to contribute to the myocardial fibrosis and the left ventricular hypertrophy and the dysfunction that is so prevalent in patients who are on long-term on dialysis. And we also add problems ourselves by the things that intervention that we do. So not only is it dialysis that we prescribe to our patients that adds to the cardiovascular risk, but also the AVF, like the vascular access that is we promote for all of our patients. So AVF encourages a high cardiac output state, and which also puts pressure and contributes to hypertrophy of the left ventricle. Other associations with left ventricular hypertrophy includes volume overload, of course, hypertension, age, anemia, and the low serum albumin. What's interesting, though, is that your traditional risk factors, there are some differences. There's some different behavior. Obviously, we all know obesity to be a traditional risk factor for cardiovascular disease in the general population. But patients on dialysis, you get a paradoxical protective effect, which is sort of been an area of interest for a number of people. You also don't get the mortality association with elevated LDH in patients with dialysis on dialysis. So what is this obesity paradox all about? Okay, as I said, that obesity is a known risk factor for CKD itself, and also for cardiovascular disease. Okay, but somehow when we have end-stage kidney disease and you're on chronic dialysis, obesity has suddenly become a protective factor. So, and this effect has been demonstrated independent of demographics, independent of comorbidities and other nutritional markers. As you can see from this large cohort of 122,000 patients on hemodialysis, that BMI of normal BMI of like 21 to 23 is actually associated with increased mortality. 20 increased mortality. When you get a BMI of 25, what will traditionally classify as overweight, you suddenly get a protective effect. BMI of 80, very protective. Moderate obesity, even severe obesity, BMI of 40. These patients tend to do much better than patients who have what we classify as normal BMI. So it is thought that the better nutritional status that comes with, we can say is better, that comes with obesity, confers a survival benefit. And this is thought to be protective against inflammation, is protective against infection and cardiovascular disease. And it has been shown that both higher skeletal muscle and increased body fat are protective for patients who are on dialysis. However, there is mixed data on visceral fat. Higher waist circumference has been shown to predict mortality in some studies, but not in all. So there's some area of controversy there. And the survival advantage that is clearly evident with hemodialysis is not so evident with PD. We have a number of studies which contradict this particular aspect when it comes to PD. So, however, this is not something unique to chronic dialysis. You get this metabolic, what is called metabolic healthy obesity, also with patients who have chronic heart failure, patients who have HIV malignancy, where you get this paradoxical obesity paradox. Okay. The weight changes are also associated with adverse effects, especially progressive weight loss has very, very poor survival, and weight gain is associated also with decreased mortality. What about your non-traditional risk factors? So these are also play a major role in modulating and influencing the cardiovascular risk. Inflammation is important. The oxidative states that are associated with not only dialysis but also the chronic kidney disease state, endothelial dysfunction, and the accumulation of advanced glycation products. As you can see from this study, this small cohort looking at CRP, that your CRP followed up over 48 months. So those with higher CRP had much worse survival than those with low CRP. So your cardiovascular mortality is very much linked to inflammation. And contributing factors are thought to include the kidney failure itself, the dialysis process, as I've noted, that the dialyzer itself induces this chronic subclinical inflammation. The water quality also can push a background chronic inflammatory environment. In the vascular excess that we've got, catheters associated with more inflammation compared to fistulas. Coronary artery, so how, besides sudden cardiac death, how does this cardiac complication manifest? So coronary artery disease is quite common in advanced CKD. Patients who start dialysis, almost a third of them have already advanced, have a diagnosis of coronary artery disease. And another third have got coronary artery disease, but it hasn't been diagnosed yet. So this is one of the reasons why we screen and patients are excluded from the state dialysis program because of the prevalence of coronary artery disease and its association with high mortality. So not only is coronary artery disease common in advanced CKD patients on dialysis, but also the complexity is also quite common. It's also quite complex. Coronary plaques are characterized by increased media thickness and arterial calcification. And often these patients are asymptomatic and they may present with atypical symptoms. Okay. As this can be due to uremic neuropathy or be due to coexistent diabetes, but it's not uncommon for CAD to present with just an unexplained dyspnea or just a frequent interdialytic hypotension, or frequent heart failure exacerbations. And as you can see from this study, that classification, the longer you're on dialysis, the higher the chances of your vessels become calcified. You can see the proportion of calcification almost reaches 100% after 20 years on dialysis. So the dialysis vintage is a major modifying, major factor influencing the health of your vessels. Arrhythmias are also important. They're a major contributor to sudden cardiac death, particularly ventricular arrhythmias. We blame this to intra-myocardial fibrosis, which disturbs the electrical circuitry of the heart and leads to ventricular thermogenesis and encourages the re-entry pathways. Also, the dialysis procedure itself is also a major contributor to this. So if you have interdialytic accumulations of solutes, patients who frequently are non-compliant to their diet and fluid, and when they come on Monday, you have to remove a lot of potassium, calcium. So these major shifts of solute and fluid are associated with ventricular arrhythmias and sudden cardiac death. Ventricular arrhythmias are difficult to actually quantify, but atrial fibrillation is a bit easier to get a gauge in the population. You can see that the incidence rises with age, and also the prevalence as you get older, it rises. And when you have atrial fibrillation and you're on dialysis, the mortality risk is you can see more than twice as high, right, for the patient. So what does the act of dialysis do to the myocardium? Okay. You know that when you put a patient on dialysis, you induce an ischemic event. The ischemic event is not only directed towards the kidney side, but more importantly towards the heart. You get myocardial ischemia, which is associated with myocardial control function impairment, and also affect patient survival. As you can see here, that patients with regional wall motion abnormalities at 12 months, that you get a significant functional defect, as opposed to those who don't have regional wall motion abnormalities. And also, when you look at those patients at baseline who have segmental function abnormalities of more than 6%, that even at rest, you get a reduction in ejection fraction. And also on dialysis, there's a quantifiable reduction in ejection fraction. Okay, so the dialysis is not a procedure, is not benign procedure. So what can we do? Okay, for left ventricular hypertrophy, exercise has been shown to be of some benefit. In North America and Europe, this trend of the intradialytic exercise, giving patients some bicycle to ride on while they are on dialysis. This has been shown to improve blood flow, especially to low perfused tissue areas, and associated with increased solute clearance, and can improve dialysis adequacy. And 60 minutes of doing the shuffling is equivalent to 10 to 30 minutes extra time on dialysis. And what does it do to the heart? This exercise, you can see here that after exercise, there's less stand segments, and there's less peak stand segment just by allowing patients to exercise during dialysis. What about your ACE inhibitor? ACE inhibitors are important in your non-dialysis population. Do they have been shown to be of mortality benefit? The unfortunate answer is no. Okay, ACE inhibitors have been shown to reduce left ventricular mass, but they've been disappointing in terms of lowering the cardiovascular mortality. Spironolactone, this study, Doha study published in 2014 was at least gave us some armament in showing that spironolactone can reduce cardiovascular morbidity and mortality. So there was a significant separation of the curves when you use spironolactone in patients who are on dialysis. Beta blockers, carvedilol and atenolol have shown some promise in small studies, but large, cohort was disappointing. There was no association. However, this was a secondary analysis, so more work is needed here. Statins have not shown to be of any benefit in terms of mortality, improving cardiovascular mortality for patients on dialysis. Although it is recommended that if a patient is already on statin, that you continue, but statin just for the benefit of cardiovascular reduction has not been shown to be of any value. And what about reducing intradialytic myocardial? Increasing frequency of dialysis it can be of benefit, prolonging time on dialysis, limiting water filtration rate, avoiding large electrolyte shifts, and modifying your dialysate components. Arrhythmias, implantable defibrillators have been disappointing, and they are more likely to give infections rather than actually improve survival. Subcutaneous implantable are being explored. Okay. When it comes to anticoagulation, warfarin is problematic. No warfarin is excreted by the kidney. The metabolite predominantly excreted by the kidney. So there is a bleeding risk that is associated with warfarin. And also warfarin has been linked to vascular calcification. Oral anticoagulant are showing some promise, although most studies have excluded patients with advanced kidney disease and those on dialysis, although a few have been approved by the FDA for those patients on dialysis. So what about coronary artery disease? Management in this regard is very controversial. We can see that there's no benefit if you cabbage them or you PCI them, and those who have had intervention because of the revascularization, they are 5 times to 6 times more likely to die, and there's a higher 5-year mortality revascularization. So this results in predominantly patients who are on dialysis, nothing for them to put on medical management. So over 76% of patients who have coronary disease tend to be put on medical management, and only a few get PCI. As I've said, also the statins have been disappointing in terms of reducing mortality, and the EVOLVE trial was disappointing also in trying to show some benefit in senior acid in terms of attacking the calcium phosphate angle, in mitigating against the risk of coronary artery disease. What do we know is that you don't want a high hemoglobin. A high hemoglobin is associated with increased cardiovascular events. So more than 3 trials have shown this. So this is one adverse event that is within our range. there are not that many trials that have been performed on patients who have advanced kidney disease. So ischemia trial was because they included each about 700 patients with eGFR of less than 30, and half of those patients were on dialysis, so they were randomized either to invasive therapy or conservative therapy for their ischemic heart disease. It was disappointing as there was no mortality benefit that was derived from invasive therapy. However, there was increased risk of stroke in the invasive strategy, and also increased risk of pushing patient to dialysis and even death with the invasive strategy. So this was it's a big blow also to things that you can have to try and manage coronary artery disease with advanced kidney disease. What about infections? So mortality risk is high in patients with on dialysis, about 3 times higher than in the general population. Vascular access, sepsis account for about 20%, but not only vascular access, but the repeated peritoneal puncture is also associated with an infective risk. Okay. What's important about patients who are on dialysis is that they typically don't mount the typical infective response. So about half of patients who got an infection, they won't have any fever. So a high index of suspicion is important. Okay. The HD treatment itself, okay, can be a source either through contamination of dialysis machine, through exposure of non-sterile water, and dialyzer reuse, which is in some centers they do practice this type of. We know that the CKD itself depresses the immune system, both the innate and the adaptive immune system. They undergo a chronic inflammatory state where there's both immune activation and immune depression, resulting in a high risk of infections such as pulmonary infections, soft tissue infections, and urinary infections. Not only more infections, but also the severity of infections is common in patients who are on dialysis. There's increased susceptibility to both bacterial and viral infections, and then also when you try to vaccine, you run a risk also. If vaccines, you run a risk of a poor response. And this immune dysregulation also contributes to the cardiovascular risk that has been described. Nutrition is also an important component, especially protein energy wasting, which is defined as reduced body reserves of protein and energy. There's a high prevalence of protein energy wasting between 28 to 54%, and it increases progressively as patients their achieve progresses. And it has adverse outcomes in terms of poor quality of life, increased morbidity, and increased cardiovascular mortality and mortality from infection itself. And the causes, they are variable. Okay. Dietary intake is important, which is influenced not only by psychological factors, but also by the loss of kidney function. So uremic toxins will not affect both the protein energy wasting and also your ability to take nutrients. Comorbidities contribute greatly to protein energy wasting, and dialysis catabolism also contribute to this. And the consequences of PW is that you are prone to infections. It also is an important cardiovascular risk, and it contributes also to frailty and depression. And this is a study that was part of my PhD in Devon, where we looked at some albumin in patients who are on PD. And as you can see, okay, we had two cohorts, one HIV positive and the other HIV negative. And it was quite evident that when they start PD, when they start dialysis, they already had a depressed serum albumin. You can see the mean here is close to 55. These are HIV negative patients who've got advanced CKD. And HIV positive patients with advanced CKD, when starting them on dialysis, they've already got very low serum albumin. And as they progress on dialysis, the serum albumin becomes worse. So this is thought to be due to the losses that happen during the dialysis itself. So you lose, in some studies, they estimate you can lose between 3 to 15 grams of albumin in the dialysate. And so it takes up to 4 months for the liver and the body to be able to compensate for the losses that are happening in the dialysate. And you can never go back to your baseline. So you can never compensate back to where you were. So the dialysis itself is a major contributor to the malnutrition inflammatory syndrome, not only for PD, but also for hemodialysis. So this study also shows that the comorbidities, be it HIV, be it diabetes, are major contributors to the malnutrition inflammatory syndrome. And this combined effect leads me to poor adverse outcome, poor mortality. So how do you approach patients who have issues with nutrition? So it's reasonable to check serum albumin, weight, BMI occasionally, and those who and to encourage continuous nutritional counseling, sending them to dietitian and optimize their diet, managing the comorbidities, and optimizing the treatment, optimizing the prescription of dialysis is important. And those who struggle, you can introduce a number of measures, such as oral therapy, even if in some severe circumstances, you can even introduce intradiabetic parental nutrition. You can have prescribed anabolic hormones if you are very, very struggling to manage malnutrition and appetite stimulants. Exercise is very important. So when it comes to supplement, intradialytic oral protein supplementation is one avenue that has come into interest recently. It has been shown to reduce hospital stays, has been shown to have better survival and improve albumin level. So they get this protein supplement during dialysis. And you can see here that survival, a number of studies have shown a survival benefit. And what's interesting about the study is that mixed treatment, so those who had supplement actually had less missed treatment, so they were coming more for dialysis, which was quite interesting. Micronutrients, you lose a lot of micronutrients in the dialysate, and also the dietary restrictions that we put on our patients lead them to be deficient in micronutrients. So it's important also to look at ways of supplementing your macronutrients. Anemia, it's a major aspect, it's an important component, and and is associated with high mortality, and EPO has proven itself in terms of improving quality of life, improving cardiac function, and also according to this meta-analysis, improving VO2 peak. It can be given subcutaneously or intravenously. The route which is better so far is controversial. Iron therapy is important. Iron patients who are on ESAs and on dialysis, they typically need 1 to 2 grams of iron per year. This is due to loss of blood from dialysis, from laboratory testing, from vascular procedures, from gastrointestinal bleeding. The most common markers of iron are serum ferritin, which gives you an indication of iron stores, transferrin saturation, which gives you an indication of iron availability. And in hemodialysis, IV iron has been shown to be more efficacious in terms of effect that is increasing, affecting the hemoglobin level. However, there is a potential increased risk of infection with IV, and the mortality benefit overall has not been elusive. This is a nice trial that has been recently published last year in the NIGE, and so it's a relatively large 2,000 patients that were randomized to proactive IV iron. So they were given IV iron even when their ferritin was high, but to maintain the ferritin below 700 and set of 40. The reactive group was only given iron if the ferritin was less than 200 or set for less than 20. There was a significant separation, although it's not appreciable if you look at the curve, but there was a significant benefit in terms of myocardial infarction, strokes, and death. So this is almost one of the few studies that have shown some benefit of IV iron in mortality benefit, but this is IV iron against another IV iron regimen. Hypertension, okay. As you all know, that is prevalent in patients who've got kidney disease. Almost 90% of patients who've got advanced CKD got hypertension. It's influenced by volume status, and the BP tends to vary, be it pre-dialysis, intra-dialysis, post-dialysis, and interdialytic period. And the easily measurable BP, that is the one just before they go on the machine, is poorly correlated with mortality. In fact, it gives you a sort of a BP paradox, a U-shaped association where we get an area between 140 to 170. A much more helpful measurement is the interdialytic BP, that is a BP at home or ambulatory BP monitoring. As you can see here, that there's a significant correlation to mortality for the home and ambulatory BP, but this BP is difficult to measure in practice. So this is much more practical. When patients come for dialysis, you can easily measure, and this is a bit more difficult. So what are the mechanisms that push and maintain BP? They include sodium volume overload, they include increased arterial stiffness, they include activation of the sympathetic nervous system, they include activation of RAS, individual dysfunction, and actually the use of ESAs contribute. What about this BP paradox? We talked about the obesity paradox. Now is the BP paradox. The BP paradox. So when you measure the pre-dialysis BP, you can see that what you consider normal BP is actually an increased hazard for death. And you get this hazard for death becomes protective when the BP is actually in the range where you consider very high. So your normal BP for a dialysis patient is not so normal. So while a BP between 140 and up to 160 is actually associated with less mortality so this was a very large cohort of 40,000 patients of chronic dialysis. You struggle to get so many patients on this study on dialysis. And this DOPS also cohort, this is an interesting one because it included a number of countries, a very large population of 24,000, also showing the same thing that lowish sort of normal BP have higher hazard for death, while the BPs where you associate with hypertension, actually those associated with lower mortality risk. And so you get this BP paradox where very high BP are harmful, but also very low in normal BP are also harmful. Sodium is a major driver of BP, of course, and recommendations vary. We know that it's a major predictor, no matter what model you use, it's a major predictor of mortality. Volume status also, it's an important component. They usually assess volume status using a clinical guesstimate, where you look at the pre and post dialysis BP, and your edema, your dilated weight gain, your jugular venous pressure, auscultation of the lung bases, and all of this has been shown to associate with intradiabetic hypertension. Actually, they damage the residual function of the kidney, and they are associated with more cardiovascular complications. And so research has been ongoing throughout the years to find better ways of quantifying BP. So bioimpedance has shown some promise with bioimpedance defined overhydration predicting mortality quite well in this meta-analysis. And the new tools that are showing some promise, things such as lung ultrasound, which is a novel technique that relies on the fact that there is excess fluid in the lung when you are overloaded, and this accumulates in the interstitium of the lungs and thickens the interlocular septum. And when you do an ultrasound, you get B lines that you can count, and this correlates well with left ventricular mass. So you have this tight balance of that you have to navigate between fluid depletion and fluid overload, with various complications on either side of the spectrum. There are some paradoxes, okay, that are linked to race. Okay, this is USRT data. So in America, African American are known to have high prevalence of end-stage kidney disease compared to other races, white, Hispanics, and American Indians. And also there's high incidence of diabetic end-stage kidney disease, both in African Americans, Native Americans, and Hispanics. And when you look at access to nephro care, actually you find that compared to white, black, they start dialysis, there's a lesser percentage who start dialysis with fistulas. For Hispanics, there's even a much lesser percentage starting dialysis with fistulas. This is seen in Medicaid, Medicare, even private. So there's an overall reduced access to pre-dialysis nephrology care in America, according to race. And when it comes to transplantation, the same. African Americans and Hispanics dialyze less, transplanted less compared to whites. However, when you look at survival, what is very interesting, which is the paradox, is that although they've more disease, they've severe disease, and they're not transplanted, they've poor access to care, African and Hispanics, they survive more. So there's higher mortality among the American whites in all age group, except for the young. And also those on transplantation, there's higher mortality of whites compared to blacks and Hispanics. This may be due to maybe that blacks, they of younger age, when they develop end-stage kidney disease, but for Hispanics, who typically have the same age demographics as whites. So this is surprising and interesting. And also, when you look at the mortality, this is seen throughout the ages. And it's seen for both blacks and also for Hispanics. When you when you adjust for transplantation, you lose some survival benefit of blacks for those less than 40, but the Hispanics persistently survive better than anyone else on dialysis. So you have this Hispanic paradox that has been described in America. So this is my last slide. So looking at depression. So depression is a major problem. It's very prevalent in patients who are on chronic dialysis. In a number of contributors, the burden of illness is a major contributor, which leads not only to depression, but also to non-adherent self-care. Lack of support is important. The symptoms, the functional impairment, all these contribute to not only to depression, but to non-adherent behavior. And non-adherent behavior then leads to uncontrolled BP, uncontrolled sugars, which have cardiovascular consequences. And also depression can directly link also to poor quality of life, which also has been shown to have cardiovascular complications. So not only depression doesn't interact with behavioral issues, but it also interacts with biological issues, comorbidities influence depression, inflammation influence depression, autonomic activity influence depression, hormonal abnormalities also influence depression, and all this also influence cardiovascular risk. So there is a connection, the psychosocial connection that links behavior, biological, and cardiovascular mortality. So what is the summary of everything? So I've highlighted the fact that cardiovascular complications are important in patients who've got advanced kidney disease who are on dialysis. Sudden death is a prevalent coronary artery disease, arrhythmias. There are patient factors, there are dialysis factors, and there are cardiac factors that contribute. And what must be remembered is that these patients, they can present asymptomatically, and they can present with atypical symptoms also. So the high index of suspicion is important when dealing with our patients. Infection risk is also high, so, and the mortality associated with a patient on dialysis who get infection is 300 times more than the population. So treating infections is important, and identifying infections is important because the consequences are quite dire for our patients. And we know that is due to not only the immune depression due to the disease of CKD itself, but also the dialysis itself, the vascular access, and also the comorbidities that are associated with CKD. And also infection doesn't present the same way, so it can be a cyclic presentation with less than 50% of patients having no fever response. Malnutrition, inflammation is important. It's a major modifier of cardiovascular mortality. And I've highlighted a number of reverse epidemiology the obesity paradox, the BP paradox, and the race paradox that has piqued interest in nephrology. And of course, you can never forget the psychosocial connection of patients who are on chronic dialysis. Thank you.
Right, thanks very much, Kwazi, for that timely and comprehensive overview. It's really great to get the update on some of the recent literature and studies, and also to just get some of the insights regarding the pathophysiology of these complications, to really kind of understand, what it is with chronic renal failure and with the process of dialysis that gives rise to these complications that we see. If I can ask the first question, and just to say to colleagues, you can either raise your hand or type a question in the chat function. But Kwazi, if I can just ask you, you mentioned the BP paradox of that the patients with the best outcomes seem to be those who run what we would otherwise regard as systolic hypertension. What are the implications for our decisions around treatment of hypertension in those patients?
Yeah, it's an area that has sort of made nephrology to struggle. There are two ways to attack that. Is one, not to allow the pre-BP, pre-dialysis BP to go low, if that is the only tool we have available to you. If we are able to get at-off dialysis BPs, your home dialysis BP or your ambulatory BP, it's better to use those. Those BP measurements can be sort of applied using the conventional BP guidelines that we become accustomed to. But when you're using the pre-dialysis BP, you have to aim for a bit higher BP. So for me, I tolerate a BP of more than 140 quite frequently in patients on dialysis, and I will rarely decrease the BP below 140. To drugs, it's difficult. I think most of our patients are on 3, 4, or even 5 drugs in any case. So we use whatever you have. There's no drug that has been proved more beneficial than other, except for spironolactone in coronary artery disease.
Yeah, and have there been any kind of treat to target studies in these patients with respect to what the target blood pressure should be, or is it this is just an epidemiological association? Yeah,
okay. RCTs are quite sparse in this population. So and the numbers that you usually get are very small, and so we don't have good quality data in terms of what to use, if these ranges are good ranges to target at. So all the data we have right now are observational data that is showing adverse outcome. But I think there's a lack of actually good quality, large number RCTs that can assist us navigate the so-called BP paradox.
And so I just wanted to ask Ashley Chin if he wanted to comment on the cardiovascular complications and particularly the issue around arrhythmias in these patients.
Thanks, Graham. Thanks, Kwazi, for that excellent talk. Yeah, I mean, there's been, with the advent of implantable loop recorders, which are basically devices that can record arrhythmias for up to 3 years, there's been a need. There's been several population groups that have been looked at, and one of them is the chronic renal failure patients. And there have been some studies now of loop recorder studies where patients with end-stage renal disease and chronic renal failure have had loop recorders implanted. And in fact, there's been quite about a third of patients can present with some form of sinus node dysfunction and even AV block. And then there's also been reports of polymorphic VT as possibly the cause of sudden death in these patients. And then about a third of these patients have paroxysmal AF as well. And Dr. Scott Lee Jones and Erica and I are supervising Scott's MED project, and he's looked at we've looked at about 30 patients in the dialysis department with loop recorders, and we in fact picked up quite a few patients with sinus node abnormalities, particularly during the interdialytic period between dialysis sessions, and maybe that's where the potassium abnormalities are at its most, where the potassium levels climb quite a lot, and also where the fluid shifts are high. So, and we've picked up I think it was about 3 or 4 patients with paroxysmal AF, and that would change management with anticoagulation. There was one patient with polymorphic VT who had presented with a sort of a sudden cardiac arrest, and then there were a few patients with asystole and heart block. So I think it is a vulnerable population when it comes to arrhythmias, and especially in the interdialytic period. So yeah, there's some data coming from your department as well regarding the arrhythmia side of things. Yeah, from the coronary side of things, they are as you said, they're a very challenging population to treat because, as you know, the risks are high for coronary disease, and the treatment options are also limited because percutaneous intervention carries at a higher risk of complications in dialysis patients, vascular problems, vascular access problems, and stents tend to restenose a lot quicker. And obviously, there are problems with coronary artery bypass grafting. So we tend to follow a more conservative approach when it comes to definitely chronic stable angina with dialysis patients in terms of medication. Yeah, but I agree, a very challenging group of patients to treat. Yeah.
And Kwazi, can I ask you one other question? If I understood you correctly, you said that, warfarin is associated with increased complications in these patients. And does that, your thinking around using warfarin in these patients, if you've got a conventional indication such as atrial fibrillation, then you have to use it anyway and just live with the consequences. Is that correct?
Yeah. Warfarin is predominantly excreted by the kidney, so it lasts longer, and although we don't advocate dose adjustment because you still gonna measure the INR, so the INR in any case is gonna dose adjust for you. It's also warfarin is not dialysable, so we have no option but to use it, and just use it with caution. There is some element of unpredictability. We have seen a lot of patients with sort of unstable INR that fluctuate, and so it's a challenging drug to use in a setting of advanced kidney disease. Your newer agents, okay, showing some promise, but the problem is that the studies that were done with the NEWACs were excluded all the patients who had advanced kidney disease. And so only, like I showed you, only 2 NOACs have been approved by the FDA, and even that approval was based on very, very small numbers. So there's much that we don't know, but so we hope maybe they may be the alternative. But to answer your question, you still have to use warfarin, irrespective of the fact that it's associated with more bleeding, and it's also associated with vascular calcification.
Okay. What's the mechanism for the calcification? Yeah.
It's not exactly known exactly what it is, but it's linked to disturbing the balance between the inhibitors and the promoters of calcification.
Yeah.
And also interact with one of those.
Okay. Okay. I don't see any further questions, and just I see Ndlovu has made a comment, a true tour de force through CKD and its complications. And on that note, just to say thanks very much, Kwazi, for the talk this afternoon. Really appreciate it.
Thank you. Thank you for the invite.
Thanks, everyone.